The drugs that antagonize the action of histamine. What is histamine? Anyone? Histamine is one of the chemical mediator in inflammation or allergic manifestations. So the drugs which are antagonizing the action of histamine, they are called antihistaminics. Now, there is a term called autocoys. Hormones সম্বন্ধে শুনেছি আমরা. What are hormones? Hormones কি আছে? Hormones are basically chemical substances that are produced by a specific type of cell in the body, like thyroid hormones. They are synthesized from thyroid gland. Insulin from the beta cell of islets of pancreas. So these are produced by specific cells in the body for action in the basically in the various parts of the body. একটা জায়গায় প্রডিউস হওয়ার পর অনেকটা জায়গায় কাজ করে. অটোকয়েজ কিন্তু তার ঠিক উল্টো. It is synthesized from various sites of the body, but they act generally at the site of action and at the site of release and synthesis. যেখানে তৈরি হচ্ছে, যেখানে রিলিজ হচ্ছে, সেখানেই কাজ করছে. So these are also called local hormones. So autocoys is a Greek word. Autos means self, akos means healing. These are diverse substances produced by a wide variety of cells in the body having intense biological activity, but generally they act locally at the site of synthesis and release. They are also referred to as local hormones. How we classify it? Amine autocoys that include histamine and serotonin, lipid derived autocoys that include prostaglandins, leukotrienes and platelet activating factor, peptide autocoys, plasma kinase and angiotensin. Now we will be discussing on histamine and antihistaminics today, and serotonin will be taken up in the next class and others on the next class. Coming to histamine. Histamine means tissue amine. The histose means tissue and amine is a radical. So tissue amine. Where are the histamine present in the body? They are widely distributed in the gastric gland, gastric mucosa, intestinal mucosa, in the lung, liver, placenta, in the blood, and in most body secretions, venoms, and in the pathological fluids. Now they are present mostly within the storage granules of the mast cells. So they are mostly stored in the mast cells, but there are also non-mast cell histamines. They occur in the brain, in the epidermis, in the gastric mucosa, in the growing regions. Turnover of mast cell histamine is slow as they are stored in large quantity there, while that of non-mast cell histamine is fast. Coming to synthesis, storage and destruction of histamine. Histamine is synthesized from the amino acid histidine, and then it is metabolized by N-methyl transferase or diamine oxidase. By methylation, it is converted to N-methyl histamine and then degraded by MAO to the methyl imidazole acetic acid. While histamine again can be metabolized by diamine oxidase to imidazole acetic acid. Now coming to the storage of histamine. Histamine in the mast cells, they are stored in the storage granules in the vesicles, storage vesicles. Now they are not present as a free histamine. They are complex with histamine. Basically is an acidic in nature. They are complex with the negatively charged heparin and negatively charged amino acids. Coming to the histamine receptors, at present total 4 type of histamine receptors have been identified: H1, H2, H3 and H4. The H1, H2 they have got clinical utility. Till now H3, H4 they have not found any clinical utility. So we are more interested in H1 and H2. Now coming to H1 receptors, they are present in smooth muscles, in the blood vessels, afferent nerve endings, ganglionic cell, adrenal medulla, brain. In the smooth muscle, they cause contraction. Particularly, their action is prominent in the bronchial smooth muscle and intestinal smooth muscle. In the bronchial smooth muscle, they cause bronchoconstriction, and in the basically in the intestinal muscle cells, they are causing cramping and abdominal colic. So they are causing contraction. Coming to the blood vessels, in the endothelium they are present. They are causing vasodilatation by number 1 release of nitric oxide and by synthesis of prostaglandin I2. And then also they are causing increased capillary permeability because of widening of the gap junction. Next, coming to the smooth, they are causing vasoconstriction of the larger blood vessels by vasoconstriction. Afferent nerve endings, they are related to the sensation of itch and pain because they act as a neurotransmitter in the afferent nerves. Ganglionic cell stimulation and adrenal medulla stimulation causes adrenaline release, catecholamine release, and in the brain they are acting as neurotransmitter. Coming to the H2 is primarily present in the gastric mucosa. They are related to acid secretion. In the blood vessels, they are causing vasodilatation. In the heart, the action is not that prominent. In the heart, in the atria, they are causing positive chronotropy action. In the ventricle, they are causing positive inotropy action. In the uterus of the rat, it causes relaxation, not that much effect on the human being. In the brain, they are acting as transmitter. But H2 we mean gastric mucosa, because H2 blockers are primarily used in peptic ulcer disease. Coming to the H3 receptors, they are present mostly in the brain in the presynaptic neuron, causing inhibition of the release of histamine, and thus they are causing sedation. They are also present in the lung, spleen, skin and gastric mucosa, presynaptically decreasing histamine release. Now, receptor type H1 is basically H4. H4 receptors, they are primarily present in eosinophil, in the mast cells, in the basophils. They are causing, on activation, they are causing increased chemotaxis of these cells, and thus they are possibly responsible for mediation of inflammation and allergic manifestations. Now, H1 receptor is basically GQ protein coupled receptors. GQ protein coupled receptor কিভাবে কাজ করে? G protein coupled receptor কি টাইপ আছে? হ্যাঁ? Sorry? ক্যালসিয়াম, আলটিমেটলি ক্যালসিয়াম রিলিজটা বাড়ায়, তাই তো? কিন্তু কোন মেকানিজম দিয়ে? By the PIP2 hydrolysis is broken down to IP3 and DAG, and thus they are causing increased release of calcium from the intracellular store. So PIP2 hydrolysis, IP3 DAG, release of calcium from intracellular store, protein kinase C activation and nitric oxide release. These are the mechanisms. H2 basically they are GS protein coupled receptors. So they are activating adenylyl cyclase, increase CAMP. And coming to H3, they are basically GO protein coupled receptors. They decrease CAMP in the cell and also cause potassium channel activation and decrease the calcium influx. The H1 antagonist, H1 basically histamine agonist, they have got minimal role in clinical utility except beta histine. We'll do it. And coming to H1 antagonist, examples are mepiramine, chlorpheniramine, H2 antagonist, cimetidine, ranitidine, and H3 antagonist as such no clinical utility. Examples are like triplolisant. Now primarily in this class we will discuss on H1 antagonist. H2 antagonist will be taken up in the gastrointestinal classes. So, pathological action of histamine on the blood vessels, they are causing vasodilatation of the larger blood vessels. How? Primarily by H1 mediated due to release of EDRF, by H2 mediated and by directly action on the vascular smooth muscle. They are also causing vasoconstriction of the larger blood vessels, H1 mediated. Increased capillary permeability, H1 receptor mediated because of widening of gap junction. They are also responsible for dilatation of the cranial blood vessels causing pulsatile headache, H1 receptor mediated. Injected intradermally, it can cause triple response, red, flare, wheal. পড়েছি আমরা রেডটা কেন হয়? Because of profuse capillary dilatation, intense capillary dilatation. ফ্লেয়ারটা কেন হয়? wheelটা কেন হয়? Second response, because of exudation of fluid from the increased capillary permeability. And lastly, flare because of peripheral vasodilatation because of action reflex. Coming to the heart, as such, no such action on the heart. In the isolated heart of guinea pig, it has been seen positive chronotropic effect and inotropic effect primarily by H2 receptor. H1 mediated negative dromotropic effect has also been seen. Visceral smooth muscle, primarily two sides, bronchoconstriction and intestinal muscle contraction. So bronchoconstriction, H1 mediated, abdominal cramps and colic on larger doses, H1 mediated. Coming to gland, there is marked secretion in gastric secretion, AC secretion da bere jay because of H2 receptor activation. Sensory nerve endings, basically histamine, they act as neurotransmitter in the afferent nerves. Injected intracutaneously due to increased histamine release, there is itching when injected. Higher doses causes pain. Now, autonomic ganglia and adrenal medulla, because of histamine receptor activation, they are causing increased release of catecholamines. In the central nervous system, histamine as such does not cross blood-brain barrier, so no central effect. But on injected intracerebroventricular, they are causing rising blood pressure, cardiac stimulation, behavioral arousal, hypothermia, vomiting and ADS release. Now coming to pathophysiological roles of histamine. Number one, gastric secretion. As we know, histamine in the gastric mucosa, these are non-mast cell histamine. They are present in histaminocytes close to parietal cell, having high turnover rate. These are here the histamine is released. Here the histamine is released under different stimuli like feeding, vagal stimulation, like cholinergic drugs and gastrin. What does it cause? On release, they activate the proton pump, H plus K plus ATPase pump, and thus they are causing acid secretion. H2 blockers not only suppress acid secretion induced by histamine, but also decrease that in response to acetylcholine and gastrin. Cano? Because vagal stimulation, cholinergic drugs, gastrin, they are also causing histamine release. So if you are giving H2 blockers, we can partly antagonize the effect of acetylcholine and gastrin on the acid secretion. Allergic phenomena, mediators of hypersensitivity reaction, histamine একা নয় অনেকগুলো mediator থাকে, like আর কি mediator থাকে histamine ছাড়া, leukotrienes, prostaglandins. So mediation of hypersensitivity reaction, only one of the mediator, H1 antagonists are effective in controlling these manifestations to some extent, not completely. Now they are basically effective in all type of allergic reactions except in case of asthma. Asthma-te kintu antihistamine খুব একটা রোল নেই, and to some extent in anaphylactic shock, where the drug of choice is Anaphylactic shock এর drug of choice adrenaline, এটা খুব কমন কোয়েশ্চেন রয়েছে। অ্যানাফাইল্যাক্টিক শকের ড্রাগ অফ চয়েস অ্যাড্রিনালিন রয়েছে, ঠিক আছে, নর অ্যাড্রিনালিন কেন নেই? Mediation of hypersensitivity reaction, H1 antagonists are effective in controlling these manifestations to a considerable extent, except asthma and to a lesser extent anaphylactic shock. These are not involved in delayed or retarded type of allergic reactions. Now, this is a schematic diagram showing release of histamine in antigen antibody reaction or in allergic reactions. Basically, in sensitized patient, IgE antibody is expressed combined with expressed on the mast cells joined with Fc epsilon receptor 1. Now what happens when patient is exposed to the antigen bind to the IgE antibody. As a result, tyrosine protein kinase is activated, that is causing PIP2 phosphatidyl inositol biphosphate hydrolysis and is converted to IP3 inositol triphosphate, that is ultimately causing release of calcium from the intracellular store. And now this calcium, they help in the fusion of the synaptic vesicular membrane with the synovial membrane and is causing exocytosis of the stored granules which contain histamine. Now, on release by exocytosis, the sodium or calcium ion in the extracellular fluid, they exchange histamine, they take the place of histamine, and histamine is set free. As a transmitter, they act as a transmitter in the afferent nerves, causing itch and pain of the sensory nerve endings. Non-master histamine in brain, particularly in the midbrain and hypothalamus. Brain also contains non-master histamine and they are responsible for wakefulness in the brain. And it is for this reason H1 antagonists, those which can cross blood-brain barrier, they have got sedative effect. So H1 antagonists owe their sedative action because of blockage of this action. H1 agonism also suppress appetite. It is for this reason one H1 antagonist, ceproheptadine, is also used as an appetite stimulant, although off-label use. So hence appetite promoting action of some H1 antihistaminics. Histamine also plays a role as a transmitter regulating body temperature, cardiovascular function, thirst and other functions mainly through H2 and H3 receptors. Inflammation by they are mediator of vasodilatation. They promote adhesion of leukocytes to the endothelium by P-selectin. They thus they cause chemotaxis of the leukocytes at the inflammatory site and they also regulate microcirculation there. Tissue growth and repair, it has been seen that the tissues which are growing or the regenerating tissues, they express a lot of histamine, and possibly for this reason it has been told that histamine plays a great role in tissue repair and growth. Headache, they are implicated in certain type of vascular headache, although role not established. Previously it was used to check the acid secreting capacity of stomach, bronchial hyperreactivity in the asthmatic patient, and for diagnosis of pheochromocytoma. But because of the risk associated with the test, it has been abandoned as not used nowadays. Beta-histine is a H1 selective analog. They are particularly used for the Meniere's disease to control vertigo. How it acts? It causes vasodilatation in the internal ear. They are contraindicated in asthmatics because they can cause bronchoconstriction. They are contraindicated in peptic ulcer disease. Now coming to histamine releases. Certain conditions or drugs can cause release of histamine from the body. That include tissue damage, any type of tissue damage, as they contain a lot of histamine, that can release histamine like trauma, stings and venoms, proteolytic enzymes, phospholipase A. Again, the antigen antibody reaction that can release histamine in the body, polymers like dextran, polyvinyl pyrrolidone, they release histamine in the body. Some basic drugs like D-tubercularine is the muscle relaxant, skeletal muscle relaxant, morphine and opioid, atropine already discussed, pentamidine, polymyxin B, vancomycin and even some antihistaminics can release histamine. Surface agents like Queen 80 and compound 4880, they are also histamine liberators. Now coming to H1 antagonist. H1 antagonist, they basically competitively antagonize action of histamine at H1 receptor. Majority of the H1 antagonists have substituted ethylamine side chain. Now, this is a classification of the H1 antagonist. We basically divide into two generations. H1 antihistaminic first generation, H1 antihistaminic second generation. Now, of the first generation drugs, they are grouped into highly sedative, moderately sedative, mildly sedative, like diphenhydramine, dimenhydrinate, promethazine and hydroxyzine. They are highly sedative. Phenidamine, cyproheptadine, meclozine and cinnarizine, they are moderately sedative. And chlorpheniramine, dexchlorpheniramine, triprolidine and clemastine, they are mildly sedative. Coming to the second generation antihistaminics, they include fexofenadine, loratadine, desloratadine, cetirizine, levocetirizine, azilastine, mesolastine, avastin, ropatadine. These are generally claimed to be non-sedative, as most of them are not able to cross blood-brain barrier. Now, pharmacological actions by antagonism of histamine, they block histamine-induced bronchoconstriction and again block the contraction of intestine and other smooth muscles, and also triple response. Fall in blood pressure by histamine can be antagonized at low doses, while for higher doses additional H2 blockers are needed. They also block the release of adrenaline or catecholamines from adrenal medulla and the autonomic ganglia. The constriction of larger blood vessels is also antagonized. They antagonize the action of histamine on the parietal cell, thus inhibiting gastric acid secretion. Cyproheptadine is basically a H1 antagonist. They have got additional serotonin receptor blocking action 5-HT2, and they are mostly used as an appetite stimulant. So cyproheptadine has additional 5-HT2 blocking action, anti-allergic action. Many manifestations of hypersensitivity reactions are controlled, except partial control of anaphylactic shock and not effective in asthma. Central nervous system, first generation H1 antagonist, they produce variable degrees of central nervous system depression, thus they cause sedation. Why? Because their ability to cross the blood-brain barrier and affinity to central H1 receptors, that is H1 receptor present in the brain. Now, individual susceptibility to the effect in the central nervous system varies individual to individual. Now, some individuals express stimulant effect like restlessness and insomnia. Now, excitement and convulsions are frequently seen at toxic doses. Second generation drugs are practically non-sedating as they are not able to cross blood-brain barrier. Certain H1 antihistaminics are used in motion sickness. Now, mechanism, possibly they antagonize the H1 receptor in the brain, or additionally they have got anti-muscarinic effect. First generation antihistaminics, most of them they have poses anti-muscarinic effect, and possibly that is the reason for their anti-motion sickness effect. Now, the drugs which are used mostly are promethazine, dimenhydrinate, diphenhydramine. Promethazine and few other antihistaminic also control tremor, rigidity, and they are helpful in Parkinsonism. Symptomatic effect in early phase. Some older antihistaminic, especially cyproheptadine, they have appetite stimulating property. Some infant antihistaminics are also effective as antitussives, especially first generation. Anticholinergic action. Many of the first generation H1 blockers, they have additional anti-muscarinic action. Examples: promethazine, dimenhydrinate, diphenhydramine, and phenyramine. Used concurrently with atropine or its substitutes, or the drugs having anticholinergic effect, the anticholinergic effect may sum up. Local anesthetic. Some drugs like promethazine, diphenhydramine, phenyramine, they have strong, while others have weak membrane stabilizing action. So that causes that makes them possessing anti-arrhythmic property and anesthetic property, but they are not used as local anesthetic because they cause irritation on the subcutaneous injection. Blood pressure. Most antihistaminics, they causes fall in blood pressure on IV injection because of smooth muscle relaxation on the alpha or the alpha adrenergic blockade. Promethazine, they have got significant alpha blocking property. So anti-muscarinic property, promethazine also has got alpha blocking property. However, the fall in blood pressure is not evident that much on oral administration, and that may cause just postural hypotension in susceptible individual. Pharmacokinetics, they are mostly administered orally, although some H1 antihistaminics can be administered parenterally, like promethazine dimenhydrinate. Conventional antihistaminics, they are well absorbed orally, they are widely distributed in tissues. First generation one can enter brain by crossing blood-brain barrier, metabolized in liver and excreted in urine. Newer drugs, that is second generation antihistaminic, they do not enter brain because they are not able to cross the blood-brain barrier, and that account for their low or absent sedative action. Now, duration of action for most of the drug is moderate, 4 to 6 hours. Some are long acting. Side effects. The side effects are frequent but mild, marked differences in susceptibility to individuals, and tolerance developed to side effects on recurrent use. Sedation, diminished alertness, concentration, lightheadedness, motor incoordination, fatigue, and tendency to fall asleep. These are the most common side effects, particularly linked to first generation H1 antihistaminic. And it is for this reason the persons are said not to operate motor vehicles or machinery where a constant attention is required. Alcohol and other CNS depressant may add up the side effect. Few individuals become restless, nervous, and unable to sleep. Second generation drugs are free from central nervous system side effects. Regular use is not advisable in children. Why? Because that can interfere with their learning and memory. Anticholinergic side effect of the older, that means first generation antihistaminics, that include dryness of mouth, blurred vision, altered bowel habit, urinary hesitancy. Epigastric distress and headache may be felt. Local application can cause contact dermatitis. Some drugs like hydroxygen, cyclizine, fexofenadine, they have got teratogenic potential in animals, and so they should be used with caution in pregnancy. Toxic, basically overdose can result in basically excitation, tremor, hallucination, muscular incoordination, convulsion, flushing. Basically more common that which occurs in the belladonna poisoning. So muscarinic symptoms are seen in overdose. Death is due to respiratory and cardiovascular failure. Now coming to second generation antihistaminics, So how we define second generation antihistaminics? They should have 1 out of 3 properties. Number 1, absence of CNS depression property. Why? Because they are not able to cross blood-brain barrier. Higher H1 selectivity. They possess lesser anti-muscarinic effect. Number 3, additional anti-allergic mechanism other than histamine blockade. Out of 3, if anyone is present, they are said to be second generation antihistaminic provided they are marketed after 1980. ठीक है? They have a narrow spectrum of usefulness and their principal indications are allergic rhinitis, then allergic conjunctivitis, hay fever, pollinosis, urticaria, dermographism, atopic eczema, acute allergic reaction to drug and the food. They have got poor antipyretic, antitussive and antiemetic effect. Now coming to each drug one by one of the second generation. Fexofenadine. Fexofenadine is an active metabolite of terfenadine. Terfenadine, astemizole, they were basically drugs that were initially marketed in the country because of the antihistaminic effect. Now they have been withdrawn. Why? It has been seen that terfenadine, astemizole, they block the delayed rectifier potassium channel. Action potential cardiac action potential delayed rectifier potassium channel কোথায় role আছে? In the phase 3 of the action potential. The delayed rectifier potassium channel opens up and that is responsible for the repolarization. Now what happens? Plateau phase. Now what happens? Basically, as the delayed rectifier potassium channels are blocked by these drugs, that is increasing the action potential duration. QTC is prolonged. That can lead to life-threatening arrhythmia. Torsades the point is. And it was seen many deaths have been reported with the use of the drug. So, astemizole, terfenadine were withdrawn from the market. Now, this fexofenadine is the active metabolite of terfenadine having low propensity to block delayed rectifier potassium channel, does not prolong QTC interval unlike terfenadine and astemizole. ठीक है? They do not interact with CYP3A4 basically inhibitor. Now astemizole, terfenadine, they were interacting with CYP3A4 inhibitors. So when the drugs were concurrently used with antifungal ketoconazole or macrolide erythromycin, severe arrhythmia were seen because its metabolism was inhibited. Now these fexofenadine, they have got no interaction with CYP3A4 inhibitor, so lesser and arrhythmogenic potential, but not entirely safe with long QT, bradycardia and hypokalemia. They do not cross the blood-brain barrier. They are free of anti-muscarinic effect. Oral absorption rapid, mainly excreted unchanged in urine and bile. Plasma half-life 11 to 16 hours. Once daily they are used. Now coming to loratadine. Loratadine is again a non-sedating antihistaminic second generation. They are long acting, they are fast acting, but problem with this drug is they can precipitate seizure. Although they do not produce any cardiac arrhythmia, they can precipitate seizure. No interaction with macrolide or antifungals. Good efficacy in urticaria and atopic dermatitis. This loratadine is a isomer of the loratadine, is a major active metabolite of loratadine, effective in half the dose, not interference with psychomotor performance and cardiac safety are documented. Cetirizine is the most commonly used antihistaminic. Metabolite of hydroxygen with marked affinity to peripheral H1 receptor. They penetrate brain poorly, so non-sedating. They are not metabolized by CYP3A4, so does not prolong cardiac action potential or produce arrhythmia with erythromycin or ketoconazole. Now, they inhibit release of histamine and cytotoxic mediators from platelets, as well as they inhibit eosinophil chemotaxis. This is an additional mechanism of cetirizine in the allergic manifestation other than histamine blockade. Superior efficacy in urticaria, superior efficacy in urticaria and atopic dermatitis. Why? Because they attain high concentration in skin when administered. Elimination half-life 7 to 10 hours. They are indicated in upper respiratory tract allergies, pollinosis, urticaria, atopic dermatitis, and as an adjuvant in seasonal asthma. Levocetirizine is the R enantiomer of cetirizine. Effective at half the dose, they produce less sedation because they are not able to cross blood-brain barrier. Azilastin. Azilastin is used more topically in the nasal mucosa. It is a newer H1 antihistaminic with good topical activity. They inhibit histamine release, and again they inhibit inflammatory reaction triggered by leukotrienes and platelet activating factor. Additional mechanism. They also, after intranasal application, they down regulate the ICAM1 expression in the nasal mucosa. Intracellular adhesion molecule 1. Half-life 24 hours and last longer due to active metabolite. Metabolism inhibited by CYP3A4 inhibitors. Given nasally, they are used in allergic rhinitis and perennial rhinitis. They provide quick symptomatic relief lasting 12 hours. Side effects are mild, local, stinging in the nose, altered taste sensation. Now, mesolastin is a non-sedating antihistaminic. They are effective in allergic rhinitis and urticaria. No active metabolite. Avastin, they are used in nasal and skin allergies, non-sedating, rapidly converted to active metabolized carbostin is a prodrug, having a half-life 10 to 16 hours. Shown to prolong QTC interval in animal studies, so used with caution in a patient having prolonged QTC interval. Rupatadine, recently introduced antihistaminic, they have got additional platelet activating factor antagonistic action. They are indicated in allergic rhinitis. Now, coming to the usage of antihistaminics as a whole, number one, allergic disorders. They are not suppressing antigen antibody reactions. They are controlling just the manifestation exerted by the antigen antibody reaction. They are effective in all types of allergic reaction except in case of asthma, and also they partly control the anaphylactic shock. Anaphylactic shock drug of choice ki ache? Adrenaline. They are effective to control certain immediate type of allergies like itching, urticaria, seasonal hay fever, allergic conjunctivitis, and angioedema of eyelids and lips. Action is slow. Adrenaline alone life-saving in laryngeal angioedema. Cannot be relied upon in anaphylactic shock. Benefit less marked in perennial vasomotor rhinitis, atopic dermatitis, and chronic urticaria. They are not effective in bronchial asthma. Ineffective in other types of humoral and cell-mediated allergies. Type 1 hypersensitivity reaction to drugs is suppressed except in asthma and anaphylaxis. Now, other conditions that cause liberation of histamine, that include insect bite, IV poisoning, abnormal dermographism, blood or saline infusion induced rigors. In all these conditions, antihistaminics can be used. Pruritus, first generation antihistaminics remain the drug of choice for idiopathic pruritus. We all know that second generation antihistaminic, they have got poor antipruritic action. Common cold, newer antihistaminics are less effective. Motion sickness. In the motion sickness, first generation antihistaminics are commonly used because of their sedative and anti-muscarinic property. Particularly they include promethazine, diamine hydronate, diphenhydramine, and phenidramine. Appetite stimulant, cyproheptadine, although off-label use. Pre-anesthetic medication, promethazine because of its sedative and anticholinergic property. Cough, again chlorpheniramine, diphenhydramine and promethazine. Vertigo. In vertigo, first generation antihistaminics are used because of their anti-muscarinic and sedative property, cinnarizine and dimenhydrinate. Parkinsonism, they are effective in early phases of Parkinsonism. Uh, uh, they give mild symptomatic relief, promethazine and some other drugs. Acute muscle dystonia, antihistaminics are used here parenterally, promethazine, diphenhydramine, hydroxyzine. As a sedative, hypnotic and anxiolytic, they are used but not as dependable as benzodiazepines. Benzodiazepines are drug of choice for sedation and anxiolytic action. Now coming to H2 antagonist. H2 antagonist, cimetidine is the first prototype drug. Then various other H2 blockers were introduced like ranitidine, famotidine, roxatidine. They are primarily used for peptic ulcer disease, gastroesophageal reflux disease and other gastric hypersecretory conditions like Jollinger-Ellison syndrome. H3 antagonists, they are not found to have till now any clinical utility, neither H4 antagonist.